um, internationally. Our goal really was to bring together perspectives on neuromedicine, rehabilitation, and robotics from across the world to see what's happening in different parts of the world, what some of the needs are, and how these needs could be met in a manner that was sustainable in different countries across the globe. And we've had presenters who've included physicians, occupational therapists, physical therapists, engineers, as a few of them. We've had a number of presenters. Every month when we offer this webinar, we've had at least a minimum of 2 presenters, both from the clinical as well as the engineering space, to really see how these partnerships could help grow rehabilitation as well as robotics across the world. And all of our presenters have had a clinician engineering team. And I'm a clinician and Dr. Johnson is an engineer, and we've worked together for many, many years, and really believe that this is a partnership that can help grow rehab as well as technology in this space. I just want to give you a brief overview of some of the topics that we've offered over the past 4 years. So we've really focused on talking about disability and rehab in high, middle, and low income countries, what the role of assistive technology is, rehabilitation robotics advances, as well as implementation, both from building robotics that can be used for rehabilitation, as well as how they could and could not be used, or what some of the challenges, as well as some of the facilitators in different countries were to using rehab robotics. We also talked about advances in rehab in low resource settings. We've talked from maybe places that don't have enough therapists or physicians, all the way to countries that might be under resourced in terms of rehabilitation professionals, as well as talking about it in the context of people who might be displaced because of migration or any of the catastrophes happening in the world. We've also discussed across the lifespan, so we haven't really focused on one specific kind of impairment. A lot of our focus has been on neurological impairments, but we've talked about it in the context of pediatrics, adolescents, adults, as well as older adults. And we haven't focused only on physical rehab. A big piece of our focus has also been talking about cognitive rehabilitation, as well as in some situations, social robotics and social robots, and how those might be great resources for certain types of populations. One of our emphasis and one of our key goals has always been affordable robotics, and how to make technology affordable for the country that we are talking about. So it's not just about trying to create something that works, but it should work in the context that we are trying to deploy it in. We've discussed prostheses for individuals who might have amputations for various reasons, as well as talking about politics and sustainability of some of these technologies that might be proposed in different countries. We've talked about capacity building for rehabilitation and had a number of presentations on how to build rehab capacity contextually in countries, as well as using telehealth as a possibility. Low-cost technology, which builds in with our affordable robotics. And low cost can be anywhere from really low-tech technologies all the way to extremely high-end technologies. We've talked about accessibility and medical devices and how those might play in this role of trying to promote access to any kinds of devices that individuals might need. We've just some of the impairments we've discussed, or some of the diagnoses we've discussed over the years, are things like stroke, spinal cord injury, cerebral palsy, and individuals who might have HIV, as well as all of the complications that might result from it. And we've gone from the spectrum of people who might have an acute disability all the way to people who are living with chronic disability. And these are just a few of the topics we've discussed over the past 4 years. And at the end, we'll talk about where we see this going, and how we'd love to engage all of you in this process as well. Through this GPMRR webinar, which again, is now 4 years, Dr. Johnson and I really were wanted to make this something that was available both in educational as well as in clinical spaces in the form of a book. and it led to the development of a book called Rehabilitation Robotics for Neurorehabilitation in High, Low, and Middle Income Countries: Current Practices, Barriers, and Future Directions. The first edition came out a little over a year ago, where in October 2023. This is a QR code in case you're interested in looking at the publisher website for the book. Um, but it really generated from the discussions we've had in this webinar. And a lot of people who have attended this webinar are actually authors on this book, and this is how we created the our author list, and our collaborators who helped us really talk about things in contextually within their countries. We could not speak to every country and what was happening in it, but the authors really helped us, really cover a large spectrum of the world across high, middle, and low income countries. We had four major goals in this book. The first was to really describe what current practices in neurorehabilitation and state-of-the-art research of stroke rehab using robot systems were in selected high-income countries and low and middle-income countries. So obviously, we could not cover every country out there, but we tried to get a spectrum of countries across continents, and that covered both high as well as low and middle-income countries. We wanted to talk about potential solutions that allowed these technologies or rehabilitation robot systems to be available to clinicians worldwide. And this was regardless of country and economic status. We wanted to talk about what were limitations, why weren't people using it? And in countries where they were being used, what enabled them to promote the use of these technologies? We also, within our chapters, every chapter had an engineering and a clinician team. So we really wanted engineers and clinicians to write together. In some cases, these teams already existed. In some cases, we helped promote or facilitate the development of these teams, which have now led to further efforts in those countries to really talk about how we facilitate the availability and accessibility of robot systems. So just developing these systems is not enough. How do we actually get it to the clinic? And how do we ensure that it's being used to promote function and quality of life in individuals with neurological conditions? And finally, we provided examples of how robot technology or robotic technology was used to bridge rehabilitation gaps, especially in low middle income countries, where there is a shortage of rehabilitation professionals, whether they are physicians, occupational therapists, or physical therapists, to really talk about how they could promote and offer access to rehabilitation to individuals who might not typically get it because of some of these resource limitations. So I'm going to move into now talking a little bit about some of the statistics and some of the resources that exist worldwide and what some of their limitations are as well, for us to understand where we are in terms of rehab technology today. So according to the WHO, 15 million individuals experience a stroke worldwide each year. Approximately a third of those who are affected have lifelong functional disabilities. And these disabilities can vary from being extremely severe to sometimes mild, but can significantly impact their function. Whether we talk about performing daily living function or being out in the community, being able to work or regaining independence, it really has a pretty significant impact on how people are able to function. In the world, stroke is the third leading cause of disability in adults. So it's a large issue that needs some innovative solution. And up to 75% of stroke survivors, that's about 3/4 of stroke survivors, experience hemiparesis or hemiplegia, and up to 53.4% experience post-stroke cognitive impairments within 1.5 years post-stroke. So even when the stroke has become chronic, individuals are still experiencing severe limitations, both physically as well as cognitively. In 2019, there were about 101 million people in the world living with impairments due to a stroke. And 89% of stroke deaths and disability was in low and middle income countries. So these countries, there was a significantly higher number of people who were either dying or experiencing pretty severe disability compared to high income countries. And that was problematic. That is problematic in our findings. In high income countries, the stroke death rate is about 2.1 per million each year, while in low and middle income countries, it's about 7.18 per million, which is a pretty significant difference when we look at the number of people who die because of a stroke. The number in low and middle income countries is much higher. And there are several postulated reasons about why that might happen, and one of them is access to rehabilitation post stroke. However, when we look at the differences in the number of doctors and physical therapists in HICs, which is high income countries, compared to LMICs, we see a significant disparity. Just as an example, in 2018, there were about 2.6 doctors for every 1,000 people in the USA. So in the US, there were, every 1,000 people had access to about 2.6 doctors. While in LMICs, especially in sub-Saharan Africa, there were about 0.05 to 0.8 doctors to every 1,000 people, which again, the number and the disparity in that number is very significant. Similarly, there were about 0.66 physical therapists and 0.4 occupational therapists for every 1,000 people in the US, while there are about 0.0002 physical therapists and occupational therapists for every 1,000 people in sub-Saharan Africa and LMICs. So again, these numbers tell you what the access to potentially rehabilitation might be in HICs compared to LMICs. So if there were only about one in, say, 120,000 people who were physical therapists in Africa, where there are about 1.5 million stroke survivors living, then we can just conclude that access to rehab is very small. There is also a big difference in what is considered standard of care for stroke survivors in different countries. And this is not only in HICs versus LMICs. We also see differences in different HICs and in different LMICs. And so there is no one standard of care guideline, which in some ways might help countries adopt them with some cultural adaptation. So understanding what good quality of care is and what successful quality of life is really difficult, and really difficult to compare across countries as well. And I'm just going to give you a few examples. So we did a review of clinical practice guidelines across the globe, especially in countries that we covered within our book. So there are some international guidelines. When we talk about guidelines, they at least clinical practice guidelines for stroke, what they are intended to do is to inform stroke rehabilitation and what best practices across the world. So there are guidelines that exist in high, middle, and low income countries, but there are also guidelines that are offered by international organizations like the World Health Organization and the United Nations. So when we talk about the United Nations, in about the 1990s, the United Nations came out with the Convention on the Rights of People with Disabilities. And one of the key things in this document that they produced was the right to rehabilitation. However, they acknowledge that access to quality of and rehab services across the globe varies. So although these guidelines exist and they can help to bridge the gap by providing rehab practitioners with information about what appropriate and sufficient rehabilitation is for individuals, they were not uniformly adopted. And the availability of these guidelines, the quality and how they were implemented were different from country to country across the globe. In addition, the WHO launched a document in 2017 called the Rehab 2030 Initiative, which was intended to be adopted by all member states of the WHO, any development partners, and just society in general. And one of the big things in this rehab guidelines was that we need to improve rehab services across the globe, despite the fact that there is very limited practical guidelines on how to do it. So they acknowledge that it's a problem, it's not available, but at the same time, we don't have enough guidelines on how to do this. And so they subsequently published the Rehab in Health Systems document, which provided recommendations specifically to government leaders and policymakers on how to strengthen rehabilitation service delivery and how to integrate it into health systems and to improve the quality of care. A big piece that was really promoted in this document was that rehab needs to be interdisciplinary. You can't just have one professional trying to provide rehab services. It really has to be across the continuum of care and has to be provided by multiple professionals. Then the World Stroke Organization released the Global Stroke Services Guideline and Action Plan in 2014, which was really targeted towards low and middle income countries and provided evidence-based recommendations on how to provide rehabilitation across the care continuum. That means all the way from acute care to when people are living back in their homes or in the community with chronic stroke. And some of their key recommendations were specialized stroke rehab units, initial assessments, all the way to follow-up assessments, intensive task training, adaptations and adaptive training, assistive technologies, fall prevention. So things that people might be doing, but sometimes might not be available uh, regionally or locally within all stroke rehab units. Although the intent was really to try to promote the use of these guidelines across the globe, especially in low and middle income countries. And finally, another more international kind of guidelines was proposed by the European Stroke Organization, and they call it the European Stroke Action Plan 2018 to 2030. And this was intended to set guidelines for stroke rehab that would be accomplished by 2030. And again, several of their major guidelines were basically having dedicated stroke units and establishing national plans, especially within the European Union, to address all elements across the continuum of care. So these are some more broader guidelines that were intended to help promote stroke rehabilitation and offer some suggestions and ideas about how to create best practice stroke within the stroke rehabilitation within different countries. We then looked specifically at high-income countries and low-income countries, low and middle-income countries within our book. And in our book, we covered several high-income countries as well as low and middle-income countries. And I'm just going to talk about, I'm not going to go into detail about each of these, but talk about some of the overarching ideas that came up in some of these guidelines. So in high income countries, and we, the classification of high income and low income, low and middle income countries was determined by what the World Bank publication was about which countries are considered, which fall into each of these categories. And we had several countries in high income, including the United States, Canada, Australia, South Korea, Japan, Spain, Italy, and Israel. And many of these countries, except Italy and Israel, had country-specific guidelines for stroke rehabilitation. So they have publicly, nationally available guidelines that any organization or practitioner can take and use when trying to determine what rehabilitation should look like. In Italy, they had guidelines, but they focused specifically on thrombolysis and intra-arterial interventions in ischemic stroke, in acute ischemic stroke. While in Israel, there's a national stroke registry, but guidelines were limited. So although they kept track of who experienced a stroke and kind of kept track of them across the continuum, there were no specific guidelines. However, when we looked at high-income countries, there were some similarities across the recommendations, but they were not consistent. So we saw that there were several things that talked about looking at clients across the continuum of care, all the way from acute care to home or community-based care. And the need for stroke clients or patients to be treated by an interdisciplinary team. However, what that treatment consisted of varied from country to country. Next, we looked at low and middle income countries, and tried to look at, what some of the similarities, differences were, or if these countries even had guidelines. There was a systematic review conducted in 2021 that identified country-specific stroke guidelines in low and middle-income countries, and this was done by Yaria and colleagues. And what we overall generally found was that low and middle-income countries typically did not produce guidelines that were standardized. Some had guidelines, but they weren't standardized. They did not have a lot of transparency in how they were developed. So who were part of the team? Were clinicians included? What was the purpose of these guidelines? That transparency wasn't available. In upper and lower middle income countries, we found that less than 1/3 of the countries, so including 3 upper middle income countries, that's Mexico, Colombia, and China, and 2 lower middle income countries, Cameroon and India, produced stroke neurorehabilitation guidelines, while one country, Turkey, published only recommendations for patients with post-stroke dysphagia. Uh, Guidelines from upper and lower middle income countries lacked uniformity. However, some of the recommendations were pretty consistent. For example, they all said that patients need to be treated in a dedicated stroke unit. They need to be treated by multidisciplinary teams. Although who this team consisted of varied by country. So in some countries, there were no occupational therapists. In some countries, there were no physical therapists. In some countries, it was only the PM&R physician who consisted of the team. Some countries had social workers and some did not. So this team was really differed by country. And so without guidelines, very often countries or rehab just relies on what the health provider decides is appropriate care. And so if we want to standardize and provide best quality of care, we really need consistent standards and standards that meet the needs of the country where they are being developed. Nobody can develop these standards better than people in the country and who are actually involved with care of clients. So from a clinical perspective, what are our next steps? So, no matter which country, and hopefully we have a number of countries represented here today, there should be efforts towards systemic policies and guidelines on stroke rehabilitation, including in settings that are really low resourced. Interprofessional practice is the best. So that's the best way to make sure that a client's receiving all of the care they need. Really integrating technology, whether it's high-end technology or low-end technology, to maximize therapist time, especially when we have limited therapists and their expertise is highly valued. We want to make sure we're maximizing that, and technology can help do that. And then we want to clearly document outcomes. So really assessing a client at the beginning, as well as during intervention, as well as at the end, really helps us show that what we are doing works. And finally, within our organizations, really focusing on that we're providing the best quality of care and that we are working to constantly improve quality. And a lot of these first 4 steps can help us improve quality of the care that we provide. So I'm now going to turn it over to Dr. Johnson, who's going to talk a little bit about technology within these contexts and systems.
Thank you, Rochelle, for that presentation. I was just going to ask if anyone have any questions. You can go ahead and either put them in the chat or share them in the Q&A, and we'll try to leave time to make sure that we have a robust discussion. Let me go ahead and share my screen here. So as Rochelle already talked about, the whole reason for us having, I just realized that my is on a slideshow. 1 second here. Nope. The whole reason is because we're dealing with shortage, and we all on the call as clinicians realize, or as engineers realize, growing population, growing and fewer number of people able to take care of the population and the gap in care. And we all believe that technology can bridge this gap. My lab and others possibly on the phone call, and the goal of the book, we wanted at first to talk about therapy and assistive robotics and mechatronic systems. And we quickly found out that in some countries, there wasn't, might have been a luxury to even begin to talk about robotics. And the folks that contributed to the book, we asked them, if you did not have assistive robots or therapy robots like the ones that we're showing in this particular slide, then tell us why. What are some of the barriers? What are some of the issues that were preventing the uptake of these systems, and what exists and what may have worked? So I wanted to just kind of stop and reiterate something that I think is important, and I always reiterate in whenever I do these slides. And the reason for Rochelle and I partnering on this book as well is because we really firmly believe that that the solution is not all robot and given the challenges worldwide, that we want to really think about the robot being the third entity in the room, where the therapist or the clinician is working with the patient in terms of whatever role that they might be in at that time. So I just kind of want to reiterate that's our essential philosophy and how we want to kind of present this book and push this forward. And hence the reason for having clinicians and engineers and technicians present together, and professors who are in the engineering or the clinical world present their chapters together. So just to give a brief recollection, in that we've been kind of tackling this system of high-tech rehabilitation robots for therapy, upper and lower, for probably a good 20, 30 years, I want to say 30, 35 years. And since then, there's been a really a plethora of review articles talking about effectiveness. And when you kind of run the PubMed, for example, you see just the increase of the numbers of articles writing around rehabilitation robots. So clearly the interest is there. Clearly the need is recognized. And there are some things that we're all as a group saying, hey, there's some really good things about this that we want to kind of promote. So some of the pros is the enabling of semi-autonomous training, consistency, repeatability, intensive, being able to provide intensive training at times. We all recognize the ability for objective measures that could come alongside some of the subjective and some of the existing clinical tools that are out there that might suffer from ceiling effects and things like that. We also recognize the ability to utilize these systems remotely or in person for assessment, to support the clinician in a variety of ways, as well as the patient, to increase their motivation, to help them to move forward, as well as the ability to quantify certain things that might just be a little bit difficult sometimes with the clinical measure. And then also the ability to provide an additional service. In the book, we kind of wanted to recognize that these are the countries that were involved. Just kind of wanted to mention that in the high income countries, we had Canada, Italy, Spain, Japan, Australia, Korea, and Israel. By no means, if your country was not represented here, wasn't just a slight. We hope maybe in the future there will be a second version of this book, but these were companies that we had relations with, we knew about, they were interested, or we had we had invited them to apply and they were able to come through in the deadline. Maybe the next version will, if you're interested in partnering with us, please share. And then here were the low and middle income countries that were also invited: Mexico, Costa Rica, Colombia, Ecuador, Serbia, India, Malaysia, China, Iran, Turkey, Nigeria, Botswana, Ghana, Cameroon, Um, and we one of the things that we did, and this was a snapshot at the time, I wanted you to recognize that, is we tried to identify who was out there in terms of building or saying that they were creating robotics systems, or orthotic systems, or high-tech smart systems for neurorehabilitation, and rehabilitation in general. And these were in high income countries. We were able to find many. Many were in Germany, France, Asia, Spain, the USA, Canada, Israel, Japan, South Korea. So there were lots of activities happening in this area, and that was really important to note. What we were less kind of, and maybe more disappointed by, is just the activity in low and middle income countries not being as robust as ideally we would like to have seen them. So we kind of, from the countries that we surveyed or tried to survey, and the entities that we identified as participatory. Now, please recognize that some of these entities may have no longer be in the in the business, and then some others may have entered into as startups, et cetera, in the area. But what we found was kind of like, if you look at the percentage, not surprising. We see a lot in the North American area, Europe, we see Asia. We don't see much happening in the African area, and there may be one or two in the South America, um, or in Central America, but definitely not as many places as we ideally want. But in contrast, we were seeing that, this was a snapshot. I got this from the marketing surveys that they're doing, thinking about, like, where is the field of robotics going, and rehabilitation robotics and assistive technology in particular. And as you can see, there's just a projected increase in this space, and that majority of the spaces that are taking advantage of the potential are, again, in mostly high income countries. And I think because we see the potential there, it feels like we should be really thinking about how do we um, democratize it, in some sense, the access to these systems, as well as the benefits of using these systems. I like to quote this article. It was a systematic review from some colleagues, I believe, in Nigeria, who were talking a little bit about, pragmatic solutions, specifically targeting at thinking about stroke recovery. And they wanted to kind of think about what is transferable to low and middle income countries. And this was a quote that I excerpted that says, "Robots are not affordable." So that was the point. Then they went on to say that despite their high cost, though, there is an advantage to having them. A likely advantage is that automated interventions like therapies require less input, minimal input from rehab professionals in terms of time and effort. I read this as a hope statement, that in kind of a mixed review for what we do, in that, yes, they're not affordable. However, we recognize that there's some great benefit to be had from them if we can kind of make this cost benefit ratio a little bit worthwhile. And that if we can automate interventions, then the shortage that we're seeing in terms of ability to respond to the growing need in terms of the population, we might be able to meet those needs through technology and through the use of these systems. So I like to identify three main issues as some of the problems that maybe we can tackle as engineers. The mechanical complexity, I think some of that is not avoidable, but some of that is. Huge sizes and masses. We find that a lot of the low and middle income countries will discuss the issue of not having space, not being able to accommodate some of these very large systems. And then the high cost, hundreds and thousands of dollars. I know some of those costs are going down, but when you translate it into the local currency, we get to millions of dollars. But we all know that rehabilitation and the needs, the population that needs it, it's not necessarily, the numbers are not there sometimes to justify the full investment in these particular systems. We have seen that some places in some low and middle income countries have, in private hospital spaces, invested in these higher cost systems, but there needs to be a challenge. They're not available to the average person or to the general public and the vast majority of the stroke survivors or people with neurological conditions within those countries. So I think the practice of inclusivity, and using that word, I use it deliberately, is in a sense that it implies equal access and providing opportunities and resources for, in this case, we're thinking those with disability due to these neurological issues that are often marginalized in both high income countries and low and middle income countries. How do we make something that we are developing, that we're passionate about, I'll speak for myself, about developing and designing, able to be used by the widest variety of patients possible, by clinicians possible, no matter where they live in the world. And that's kind of the mantra in terms of why we were seeking to kind of promote these type of topics. And I think in order for this to be done, we really need to think about the barriers, usability, accessibility, and who we're using these, the impact of how do we get these systems within the complexity of the rehabilitation situation that we find in many countries. I don't think that there are, as Dr. Mendonca alluded to, there's just a lot of issues that need to be tackled. In the book, in each country, one of the strategies, we ask them to, what are their issues, what are the challenges, and what are the barriers? And we found that some of these barriers were very similar. I'll just mention a couple, and then I want to leave time for a robust discussion, so I'm going to try to wrap up sooner rather than later. So in terms of developing affordable devices, one of the things that were talked about was the fact that if we see a product in a high income country like the US and it costs $100,000, you see that it has utility and you want to bring it in. I'm in Botswana, I happen to be in Botswana right now. It's about 13 US dollars, 13 Botswana pula for $1 US. So $100,000 system is, you're multiplying that by 13 and you're getting a system that is way beyond even the average affordability. One of the things that the World Health Organization has done is think about affordability, maybe to help us think about it in terms of the average income of the person in the country. And that if we are making anything that's cost effective, maybe to consider these thresholds in our minds, that gross domestic product per capita in the US, we have, it's going to be unreasonable if we're over 3 times the gross domestic product. So, the market in the US can bear something that's up to 200,000 or a little bit more. And also maybe the population can bear that. But if you then move this product to Botswana, maybe the market really can't bear that type of price. So we should be thinking globally. If we're developing in the US and we want to translate that across the world, what do we do to make that real? And how do we build with cost in mind? Do we build different types of product that will reach different levels? How do we do this practically? A lot of my colleagues will say, well, manufacturing costs over time goes down just like computing costs. And over time, maybe in 20 years, the robots that are costing 100,000 will now cost, 10,000, 5,000. That's 20 years from now. In 20 years, we already see the rising trends. And so I feel like a part of our duty or a part of our goals as colleagues will be to, what do we do to tackle this situation today? as well as hoping and leveraging what we know will happen in the future. How do we tackle this problem so that we alleviate the challenges that we're encountering today? So this is just kind of like thinking about where we are, what we're doing, and how do we make sure that we're really thinking about the location and what the market can bear as we think about developing these systems. There are commercial robots out there, and I want to acknowledge that, because there are people trying to think through how some of these different types of devices could be developed that have a lower threshold, a lower market price, and I think I just kind of wanted to draw some attention to that. There are not many in low and middle income countries that are doing so. I want to draw attention to Technocare and the CR2 haptic, which is shown here, and the stretch robot that could be, it's now 20K. And I think more systems need to be developed with this thought in mind. Lots of systems in the startup phase. I'm going to give a shout out to Recupero Robotics. There are Mebster. There's lots of other startups that are trying to kind of work through this process and develop technology that are trying to hit that market price. And I think a part of the next steps of engineers is to encourage more of those. With some colleagues in the Italy, we had done kind of like a systematic review on affordable robotics for the upper limb, and again acknowledged a lot of systems are in the research spaces, in the laboratories, in the university laboratories, but many of these systems don't always get out into the commercial entity and to be available in terms of in hospitals. So some of the things that we actually saw, and these were also echoed in the book, was how do we get things to reduced costs using lower cost systems, mechatronic systems, using robots that can do and be multiple things. They can reconfigure, they can be reorganized in a way that can be of service. Maybe we don't say one robot that builds all, but we use lots of simpler robot systems that together can form a gym that could be utilized together. Another strategy that appeared, for example, our colleagues in Iran had developed their own versions of certain robots that would allow them to draw the cost down by using local manufacturing and resources, so that they could build in-house a more affordable system. Using innovative materials. There's a lot of work now around 3D, soft robots, found objects, intelligent biomaterials. So kind of trying to leverage, maybe bring into the team different types of engineers to try to start now thinking, how do we leverage our advanced and innovative technologies to do more. And I think some colleagues, for example, in Colombia, have started saying, well, maybe we need to be thinking about open source devices, and maybe developing a device that could be shared across a different platform, across engineers in different countries. Our colleagues in Colombia had developed a couple of systems and talked about it in their paper, where they had developed a low cost ankle exoskeleton and a social robot, and they made this an open source system. So in fact, because of that opportunity, they're now working with colleagues in Chile and other places where they have taken this information, have developed systems. I think this is a great idea in some sense too, because one of the challenges we have is that we have one-off systems here and there, but maybe building platforms that could be used in multiple places can allow us to also build up the evidence for clinicians. That's one of the issues that clinicians will identify, is the evidence, not enough evidence out there for me to confidently go forward and purchase these systems, whether they're lower cost systems or not. So we need to come together to also make sure that we're working together to work from standards that are similar so that we can, and then maybe many of these devices are in different places so we can build the evidence up for and continue to build the evidence to use these systems. This was just an example of some work that's done in Turkey where they made their own system so that they can do work. But again, a lot of the robots that we identified, they're in the laboratory and um, they're not commercially available. This is the system out of my lab. We're in Botswana. This was made kind of a version that ended up in the stroke rehab center in Botswana with Dr. Damba, who was running a small clinic here, and then we had versions of it at the hospital. The idea with the system was that it's to 1 degree of freedom robots with sensors. They're able to be controlled. This was the haptic TheraDrive that was like inspired out of my lab. I'm now working with Recupero Robotics, which is an entity, to see if this system could end up in the commercial space. And I think more of us in the university environment need to kind of have that type of philosophy. How do we get it out of our labs and into the university, into the commercial spaces? I just want to put this slide up. This was in one of the chapters, talking a little bit about some of the challenges that we should be thinking about clinically. How do we do maybe comprehensive assessment? What are some of the variables that maybe we could agree on of what are some of the strategies that we should be agreeing on that these robots should be measuring and how to measure? I think that I found that there were lots of different ways that people were using their robots. And in many ways, that made it difficult to come to consensus. Financially, I think the maintenance costs and the initial costs of robots are often not really, really thought about well. And I think we should be thinking through that as we think about taking it out of our labs into the patient perspective. The health worker concern needs to be considered, as well as training in terms of the use of the system. We've seen that many of our high-tech systems, when they get to certain places, low and middle income countries, if they break, they're often not factored into the budgets, maintenance costs, or the training needs involved in keeping someone using the system. So I think as engineers, this is one reason for really making that collaboration, with interdisciplinary, so that these things, even if from a business standpoint, so that we can think about these things. Just some observation that came from different chapters in the book. I noticed that community-based rehab and being able to deploy health workers into the community was a good idea, often used as a solution, but was understood to not be a sufficient one. That there was the acknowledgement that technology is a solution, but it actually was underused because either it was too costly, too complex, so that needed to be changed. When people have to get the technology in country, when the countries were talked about getting the rehab tech within their countries and commercially getting some entity going, it really began like private public partnership, university partnering with the hospital system, and that became the vehicle through which some of these things got into the real world. And that when the rehab sector existed, a lot of the commercial companies came out of the universities. And if you're in a place where this is, in a country where this is not happening, maybe consider, and you're a clinician there, where's the engineer, where's the university, where's the hospital system, and form that team that will then allow some of that technology to come out of labs into the clinical world, or vice versa, where you have an idea and you grab you're an engineering team or biomedical or mechanical or whatever, robotics, and you you say, hey, can we work together to make this a reality? Those were what we saw, and many reported that those were successful ways of doing this. Some key tech takeaways: affordability, multipurposeness, clinical effectiveness, trying to promote maybe sometimes we think solo use of a robot, but maybe in certain places, solo versus clinical, there could be a balance there, and that the systems should be appropriate. And you can't do this without capacity building, something that I'm realizing. I'm going to stop there, and then maybe just have us have a conversation. And anyone who would like to, I'm going to stop sharing. And I'm going to let stop sharing. I'm going to let Rochelle, if you want to unblock your mic and share. Do we want to start with the Q&A that were?
Yep. So we had a few general comments, just appreciation about the book, and talking about how the chapter by India really summarized and delineated problems and action lists. And Malaysia as a country really talked about how they implemented battery use to meet the context of their country. But we had two questions, and I'll just start with the first one. Michelle, I think this is for you. In building rehabilitation robotics, force torque sensors and motors are one of the components which ramp up production costs. Will using locally accessible sensors and motors with lesser efficiency and sensitivity not impact recovery negatively? In addition, what do you think about the integration of BCI, brain computer interfacing, into rehabilitation robotics?
Great question. You're right. The motors are often the main challenge, and as you know, in our lab, that's pretty much more than 50% of the cost, even when you're in the research spaces. I think we have to think about trade-offs, and we also need to work with engineers who are developing kind of novel technology. I've partnered with a colleague with in terms of Recupero Robotics, have partnered with colleagues that have been, let's talk about how do we get the actuator to be even cheaper, so that we don't trade off accuracy and performance, but that we try to maybe reduce the number of sensors that we need. One colleague at North Carolina University of North Carolina, excuse me, is looking at developing actuators that don't require, that use ML or smart techniques to estimate torques. I've been a part of that initiative to try to estimate the torques, estimate these, because the torque sensor alone can cost a lot of money. Can you build an actuator where the encoder is built in, where you don't need an external torque sensor? That can help drive the cost down. But you're absolutely right. Those are some of the barriers. And I'm not saying some of the challenges is in even revolutionizing the component and getting together and building a team that can kind of look at that. And some of it is in also, I have a colleague who developed a very, it's not a robotic device, it's a mechatronic system, but it doesn't use actuators, but it functions very close to many of the exoskeletons out there. It's relatively low cost compared to the other two, but it can allow for someone with a spinal cord injury to be able to stand and move around with, of course, crutch, etc. But it's a very innovative solution to the problem. So I think we don't always want to, our assumption is that we throw the most high-tech system at it. But I think if we do some thinking, I think we can innovate our way, into the solutions as well.
It's great. There was another question, and we can both answer this. Do you think investment in training more physiotherapists and occupational therapists should be prioritized over investment in rehabilitation robotics? And that's a great question. And we've talked quite a bit about this both in a couple of different countries as well as with physical and occupational therapists across the globe. And I believe there are more efforts to build the rehab workforce, but what happens in the meantime? Training physical and occupational therapists is not, it doesn't happen in 6 months, doesn't happen in a year. It's a prolonged process. And in the meantime, there are lots of people who are experiencing neurological impairments and don't have access to any form of rehabilitation. And so the goal is not to say that rehabilitation robotics, and I think I speak for both of us, are going to replace the person. They're only going to allow access or allow the therapist to provide therapy to multiple clients at the same time, especially if there's a shortage. And Dr. Johnson and I have been working, and we've started primarily in Botswana of improving access to as well as knowledge of assessments. And that's where we've begun for physical and occupational therapists, and training them in how to do some of these assessments and track and monitor what their services are doing, because sometimes policy change and some of these educational initiatives require us to show that what we are doing has an impact and is actually improving function or quality of life in our clients. And then we can go to policy to advocate for change. Michelle, not sure if you would like.
Quickly, I would just say my whole point about the engineers question, well, hey, it's not either or. I think it's both. I think we do need to, I think we need to prioritize both. Sometimes that's difficult. I think we need to capacity build in the countries where there are need, even in the US, we need a capacity build. We can't get anywhere without, building the workforce, but we also need to educate clinicians as well as make them savvy on technology as well. And then they get comfortable working with engineers, working with the interdisciplinary team that has an engineer on it. Even I was listening to a lecture today on digital health and the big data assessment and the use of technology to process that type of clinical data, mobile health technology. The use of technology is not going away. And so we also need to be integrating the education of this type of education within the allied health professional in the medical field, so that they're comfortable as well. And so maybe this, as again, interdisciplinary, really working to develop technology that could be used now.
So I know we are right about about that ending time. I put our emails in the chat. We'd love to hear from you. We are also looking for people who might be interested in presenting at this webinar. We are always looking for people who might be doing things in their countries or in their clinics that we are not aware of, and we'd love to learn more about it, as well as our attendees to learn more about it. So please email us if you have any thoughts or ideas about either wanting to present, or thoughts or ideas about topics you might like to hear about. And we will look for presenters to present on those topics. Go ahead, Michelle.
We're also looking for people to step up and maybe help us.
Yeah.
So right now it's been primarily Rochelle and I. We've partnered with the IEEE on robotics and automation. But if there are folks that's on the call who want to be a part of the organization team, I think if you please email us, maybe you can help us like organize a seminar or claim a couple of seminars that you're going to organize for us. We would really love the help. It's been 4 years, it's been a really great 4 years, and we want to continue because I think there is this effort that we're doing. There's no space, but there's not a lot of people doing this effort, and we want to like keep this up, but we do need your help. And so if any of you want to say, hey, count me in as a co-organizer, we'd appreciate it. So just send us an email. Any last minute comments if those who want to stay on?
Michelle, are you still there? So I know a question has come out about the certificate of participation. Michelle, do you want to talk about that? The participation.
Yes, please send us your send us the email, and then what we'll do is we'll send your information on to Elsevier, and then they will send you a certificate of participation. Before you log off right now, you can put your email, how to reach you, in the chat, and then say, I want a certificate of participation, and we will forward that email to Elsevier, and they will provide that. Any other questions? Okay, well,
All
we'll go
right.
ahead and end the seminar, and we thank you for joining us. We'll make sure that if you're putting your stuff in the chat, we wait before we close this webinar so we can get that information. Thanks again, guys, and I look forward to hearing from some of you.
Michelle, you want to stop recording?
Yes, I will do.